What exactly causes scoliosis? Hey, Dr. Chris Gubbels here, and today I'm going to talk to you about the different causes and types of scoliosis. A quick review, scoliosis is actually defined when someone has a lateral bending of at least 10 degrees with rotation. Now, there are a lot of different types of scoliosis. You could have something that's known as an idiopathic scoliosis, that's the main type, but there could be other things like a congenital scoliosis or a neuromuscular scoliosis, or a scoliosis that someone develops as their body breaks down and decays over time that typically happens in adulthood. The most common type of scoliosis is what's known as idiopathic scoliosis. Now, the term itself, idiopathic, means no known cause. So we don't know exactly what causes idiopathic scoliosis, but we know there's likely some genetic and familial factors along with some environmental factors. 80% of all scoliosis is identified as an idiopathic scoliosis. And these types of curves typically develop during teenage growth spurts. Now, an idiopathic scoliosis can develop during infancy, which is the first 1 to 3 years of life. It can develop as someone's a juvenile, which is defined as the ages between 4 and 10. But most commonly, they develop during early adolescence, which is teenage years. And these typically progress the most during growth spurts. There's something known as the peak velocity height, which is the first year of puberty where teenagers grow the fastest or their growth is accelerated the fastest. And generally after that first year or so of growth spurts, the curve progression tends to slow down. In adults, we could have a scoliosis that develops, but a lot of times there are people that have an idiopathic scoliosis that developed as a child or adolescence that they still have as an adult that becomes a progressive degenerative condition. But the vast majority of scoliosis, over 80% of scoliosis, are actually identified as an idiopathic scoliosis. Another type of scoliosis is actually what's known as congenital scoliosis. And people are actually born with congenital scoliosis. What congenital scoliosis means is someone is actually born with an asymmetry of the vertebrae in the body. It could be a vertebrae that is hemi-shaped or misshaped, where it's not its normal shape when it comes out. It could be shaped almost like a V or like trapezoidal, and that misshaped vertebrae causes the spine to bend or curve. Someone could also get what's known as block-shaped vertebrae, where you could have anywhere from 2 or 3 or more vertebrae that are fused on one side because they're not supposed to be fused, and then those blocked vertebrae can actually cause or drive the scoliosis to actually form and develop. If someone has a congenital scoliosis, we're not actually going to fix or cure that with things like bracing or scoliosis-specific exercise. Those could be used to help manage it, but typically those are resolved when they're more severe through surgery. Now, another type of scoliosis is what's known as a neuromuscular scoliosis. And a neuromuscular scoliosis means there's some underlying neuromuscular condition that's actually driving the scoliosis. The two of those that we see most frequently are those that are caused by cerebral palsy or muscular dystrophy. Now, cerebral palsy is when there's actually a developmental problem in utero with the brain. And so someone is born with cerebral palsy, and then that becomes a condition that can impact them afterwards. Another common one is what's known as muscular dystrophy. There's different types of muscular dystrophy, but generally muscular dystrophy is a condition where there's weakening of the muscles and someone is not able to control and contract their muscles like someone normally would. Now, with both cerebral palsy and muscular dystrophy, there's a spectrum someone can be on. We've had patients that are very high functioning, patients that have a scoliosis from cerebral palsy that can still stand, that can still walk and function pretty good. There's people in between, and there's more severe cases when someone is actually bound to a wheelchair. Now, same thing with someone with muscular dystrophy. How scoliosis develops is someone with a neuromuscular condition is they are not able to maintain an upright position of posture. And because they cannot control or hold themselves upright, the spine tends to start to collapse over time. And as the spine collapses, it actually causes a deformity to develop in the body. That could lead to an actual asymmetrical growth of the vertebrae during childhood or during adolescence, and it can also lead to an actually degenerative problem as an adult. The other type of scoliosis we see frequently is actually degenerative scoliosis. This is something we see in adulthood. Now, an adult could have a couple different things. One, they could have an idiopathic scoliosis, as I mentioned earlier, that they had during childhood or adolescence that becomes more severe or progressive as an adult, or they could have a new scoliosis that actually develops in adulthood. That's known as a de novo scoliosis or a new scoliosis. When we look at adults, it's about 10% of the population once we hit the age of 40. At age 60, it's about 38% of the population, and at age 90, it's 50%. So what we have is two things. We have one, both adults that have a new scoliosis that's actually developing in adulthood, and we have adults that had a scoliosis that they had when they were younger that is progressing and is breaking down and is degenerating and is becoming a bigger problem. What happens is when you have an asymmetrical alignment of the spine, like with scoliosis, you have asymmetrical loading or weight bearing on the spine. Part of the spine, where the inside of the curve is, the disc and the vertebral bodies and the facet joints are going to have more pressure. Because they have more pressure on the inside of the curve, the discs start to thin and wedge, and the facet joints and the vertebral bodies start to decay and break down. And as these break down, the scoliosis progresses. And as the scoliosis progresses, you get more asymmetrical loading. And with more and more asymmetrical loading, you get more and more asymmetrical wear and asymmetrical degeneration. Other things that could impact the curve is just generally your lifestyle. If someone has bad posture, if someone's doing things asymmetrical all the time, over and over, that could negatively impact someone's scoliosis. There are specific activities that could impact scoliosis. We know when we look at adolescence, there are certain groups that have a higher incidence of scoliosis. People that are involved in rhythmic gymnastics or competitive dance, even like competitive swimmers, those populations are found to have a higher incidence of scoliosis. Now, when I say competitive, I don't mean 1 or 2 hours a week. I mean someone that's doing this many hours a week, 2 or 3 hours a day, like every single day. So like someone that's highly competitive. And we can't actually say that those sports cause scoliosis, but we do know that those populations that do those competitively, there's about a 10-fold likelihood or increase in the incidence of scoliosis. So if someone has scoliosis and they're at risk, they may want to avoid those activities. If they love those things, and I would say just be very compliant with scoliosis treatment if you're going to continue to do those things. Now, the other thing that matters is location. When we see a curve in the thoracic spine, after someone is done growing, that curve has less likelihood of progressing compared to a curve in the thoracolumbar junction, which means the area between your thoracic spine and your lower spine where they meet, or in the lumbar spine. The reason curves in your thoracolumbar and lumbar spine have a high risk of progressing after growth is they don't have the rib cage and the bony structure to stabilize it. Because the rib cage is a pretty thick structure along with your sternum and your collarbones. They help kind of stabilize the scoliosis. But in the lower spine, we don't have those. And so when you have gravity pushing down, you don't have all the bony structure to support it. Those lower curves have a higher risk of progressing. When you look at adults that have degenerative scoliosis, they got to be careful about weight-bearing exercises, especially weight-bearing activities that creates a lot of pounding and repetitive compressive. Things like doing box jumps, heavy squats, heavy deadlifts. Even things like jogging can be problematic because jogging is repetitive pounding. You're better off doing things if you have degenerative scoliosis that's not as weight-bearing, that doesn't have as much pounding activities. Maybe look at doing things like rowing instead of running. Be aware of your environment ergonomically to make sure your environment is fit for you. If you work at a computer or you stand working, that you go through some proper measures to make sure ergonomically you're not doing excessive bending or reaching or putting excessive stress or strain on your body. And then also, if you do things repetitive on one side, make sure you're not, if you have a scoliosis on one side, make sure you're not carrying your bag on one side all the time. Make sure you're doing just all your activities as symmetrical or evenly on both sides as possible. One thing about these is all curves start as small curves. Curves that are bigger in adults were at one point smaller in adulthood, and all curves that are big in adolescence and childhood began smaller. So the recommended guidelines are: 1, all girls should be evaluated for scoliosis or do a scoliosis screening at the ages of 10 and also at 12. and boys should be screened for scoliosis at least once between the ages of 13 to 14. Now, if someone has a small curve and maybe they're not a candidate for treatment, they should have a regular checkup at least every 3 or 6 months, and new radiographs should be taken probably every 6 months to see if that curve is progression. Early detection leads to better early on treatment and better overall outcomes. And if someone is not a candidate for treatment, or they choose not to do treatment when they're adolescent, their curve should be monitored at least every 3 months, probably a physical exam, and a new x-ray every 6 months so we can see if that curve is progressing during growth spurts. If adult has scoliosis, depending on the severity of the curve, how that curve is impacting them, they should get regular checkups. So adults, if they know they have a scoliosis, should be checked literally every year to 5 years, depending on the severity of that curve and how it's impacting them. So if there's an adult that has a 30-degree curve and it's not creating a lot of problems, probably every 4 or 5 years at least, they should get a new x-ray to see if that starts to progress or become more severe. But let's say someone has a 50-degree degenerative scoliosis that's problematic, they should have that assessed at least every year, while coincidentally doing some kind of active treatment to properly take care and manage that. We treat these all differently, and they all need different types of treatment. And conservatively, the goal is always, one, to prevent surgery, and then two, if we have an adolescent, is try to stop or slow the progression. If we have someone that has a neuromuscular scoliosis, we're not trying to straighten the spine. We're generally trying to slow the spine and keep the spine from collapsing. But if we have an idiopathic scoliosis, not only do we want to prevent that from progressing and becoming surgical, in those cases, we actually, a lot of times, are trying to reduce the size of curve. The reason we want to reduce the size of curve in adolescent is we know if an adolescent has a curve that is 30 degrees or lower, when they're at skeletal maturity, they have a less likely chance of progression in adulthood. Curves at 30 degrees or more have a moderate risk of progression after skeletal maturity, which means when they're done growing, and curves over 50% is pretty much 100% guaranteed. The curves will keep progressing and become more severe even when they're done growing. When we look at adults, we could do treatments like both scoliosis-specific exercises or bracing or a combination. But in adults, the goal is not typically to work on reducing the size of the curve. In adults, the goal is to reduce pain, is to allow adults to function normally, to do the normal daily activities, and to stop or dramatically slow the rate or progression of the scoliotic curves. So there's lots of different causes of scoliosis, from idiopathic to degenerative to neuromuscular to congenital to even some of the other secondary conditions. And different types of scoliosis need to be managed different, and all treatment needs to be very specific for the type of scoliosis, the individual, and also the size of the scoliosis, how progressive that scoliosis is, and how likely that curve is to progress, and also how that curve is currently impacting someone and what everyone's goals are. So it's important to understand the different causes of scoliosis, and then really understanding how to make custom treatments per patient based on what's causing their scoliosis, what treatments are available, and also what the patient wants.
So if you're finding this information useful, like, follow, or subscribe, and share with others you think would benefit from this information. And if you have scoliosis or you have a child that has scoliosis, don't hesitate to reach out. Just give our office a call and ask for a free consultation to see if there's something we can do to help you.